Sir, we are live now. With all your permission, I'm starting this session.
Okay, okay.
Good
So,
afternoon, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, Dr. Uday Kumar Jadhav, sir. Sir has done MBBS, CHIV, PDCR, AFIH, Infectious Disease Consultant, in charge ART Center, LNT MDACS Mumbai, and owner of Life Care Clinic, Total Care in HIV AIDS, Aurangabad, Maharashtra. Attached to Pancreas Super Specialty Hospital, Aurangabad, Maharashtra, and consultant at Sharda Hospital and Critical Care. Today he is going to discuss on a topic prevention of HIV from HIV positive mother to child. Let me tell you overview of the topic. Preventing mother to child transmission, that is PMTCT, of HIV is a critical strategy in the fight against HIV AIDS. PMTCT refers to measures that can be taken to reduce the risk of HIV transmission from a HIV positive mother to her child during pregnancy, childbirth, and breastfeeding. When it is implemented correctly, PMTCT interventions can reduce the risk of mother to child transmission of HIV to less than 5%. To know more about this topic, I would like to invite Dr. Uday Kumar Jadhav, sir. Sir, over to you. Kindly proceed from here.
thank you very much, Faraz. Good afternoon, everybody. Uh, as we know, HIV has been one of the dilemma of the whole world, a pandemic that reached each and every person, otherwise or not. And we have been suffering, and we want that we should curb the HIV epidemic pandemic, and we should not allow this to spread to the next generation. We had diseases, pandemics all over the world long back, like tuberculosis, leprosy, and SARS, and now Corona. But the way this disease spreads in a particular way from mother to child has a more impact on the next generation, which is not unable to understand. So today we are going to see how lucidly we can understand and prevent mother to child transmission of HIV. So, as we know, every week 5,000 young women aged about 15 to 24 years old around the world, they acquire HIV. Now, what is the reasons of getting this HIV? The reason is that these people or young women are pregnant, and therefore they get infected with HIV virus. And during the childbirth, they also pass this to their new generation. So if you see that India has estimated about 1,45,000 children aged less than 15 years who are infected with HIV and AIDS. Now 1,45,000 children and growing. So the children account for 7% of all new HIV infections. And this happened due to not indulging in proper safe practices. So without intervention, as we see, there is a 15 to 30% risk of HIV transmission from mother to child during pregnancy. We can see that more than 10,000 infected babies may be born annually, and therefore we should take a great proper situation so that we can curb this or control this. In India, preventing mother to child transmission, PMTCT of HIV remains one of the foremost challenge in the community. Now, what are the reasons of this challenge? Let's see one by one. So HIV in women in India is one of the important pillar for transmission of HIV. Now, as we see, there are indicators and there are number of patients. The number of women who are infected in India is 1 million. There is about 40% of total population of HIV. Then number of annual pregnancies in India is about 30 million, and estimated number of HIV positive pregnancies are more than 22,000. So in 2020, we have seen that 85% of pregnant women with HIV received ART to prevent transmission of HIV to their babies during pregnancy and childbirth and to protect their own health. So delivery and breastfeeding increase the transmission for 10 to 50%. So these are the channels like breastfeeding, And during the delivery, there are a lot of chances if the mother and her child are not under the medical supervision, then the risk increases. So what have you done to control that? Let's see. So what the data shows that the pregnant woman in need of prevention of mother-to-child transmission services is more in Maharashtra, Bihar, Uttar Pradesh, Karnataka, Andhra Pradesh, Telangana, and Gujarat. So we see that these are the major districts in the major states in the country which have a lot of number of patients. So nationally, if you see, there are more about 20,000 patients who are pregnant women who require ART to prevent mother-to-child transmission of HIV. Now there are different studies that has been done, and we have found that the prevalence of mother to child transmission in India is high in areas where mother and child are not under the institutional coverage of the pregnancy. If she is not concerned with the government, we cannot get the data. There are less number of testing done, and when the less number of testing are done, then we cannot find out the people who are HIV positive. We cannot treat them with ART. So it is seen that the prevalence of HIV from mother to child transmission is about 8.76%. That is very high of the population in India. So if you see mother to child population transmission by region, maximum is in the Western India, Southern India, and Eastern India has the least, because the people in the Eastern India, the transmission mode is more of injection drug use than of sexual work. In Western India, it is more of sexual work, and in Southern India also more of sexual transmission. So what exactly is parent-to-child transmission? Now there are two terms: the parent-to-child transmission and prevention of mother-to-child. So parent, as we know, the husband and wife both are responsible for newborn babies, and therefore transmission only due to mother should not be considered. So it is the parental investment by the male partner who transmit the infection to his partner. In India, this phenomenon is aptly termed as parent-to-child transmission, because both mother and father are responsible for the child and its treatment management. So, what are the factors that are influencing the parent to child transmission? The first and foremost factor is the high viral load. The people who are not under treatment, the people who have resistant virus, have high viral load, and viral load, when not tested, we don't know, then it gets transmitted to the baby. Also, resistant trend. Now, lot of viruses are coming which are having new resistant patterns, new CRF, new URF, and these particular patterns can lead to high resistant strains. Thirdly, we have viral, bacterial, parasitic placental infection. These are some kind of infection which can be there, and this can also lead to high increase in the PMTCT. Then also the advanced clinical stage. Sometimes what happens, the mother comes in third trimester or due birth, and therefore it is very difficult for them to make them or treat them with all the factors that are there. There are concurrent STI. Most common syphilis, gonorrhea, herpes zoster, herpes simplex virus, genital herpes is very common, and this can also lead to the PPCT. Then also recent infection has high viral load and malnourishment. So these are the things that help to increase the spread of HIV infection from mother to child. So whenever a person knows or thinks that he or she might be HIV positive, they should rush to the center and get treated immediately. Get tested immediately. If you are tested, definitely after the testing, we know that definitely the person is infected or not. And people who are having high risk behaviors, they should test themselves regularly so that they know that if the infection is there in the body or not. Now, what are the stages or parts in which the risk of the transmission of virus is there? So these factors include three parts. Number one is obstetrical risk factors. That is when the baby is in the uterus and growing, then there is a part of infection. Secondly, infant risk factors, in which when the baby has been delivered, there are chances you can get. Thirdly, infant feeding risk factors, that is breastfeeding and parts in which HIV can transmitted. Now coming to the first, obstetrical risk factors. If there is uterine manipulation or amino, external syphilis version, etc., then there are chances the baby can be infected. If there is prolonged rupture of the membrane that's more than 4 hours, then possible, then baby can be infected. If there is placental disruption, abruption, or chorioamnitis, or intrapartum hemorrhage, invasive fetal monitoring like scalp electrode or scalp blood sampling, then also there are chances the baby can get infected. Invasive delivery techniques like episiotomies, forceps, use of metal cups for vacuum deliveries, and vaginal delivery versus cesarean section. So we see that vaginal deliveries have the highest risk as the baby has to move from the vaginal canal and then it can get traumatized and then the baby can have more chance of HIV infection. On the contrary, if we do a cesarean section, the baby is pulled out very easily and does not have any kind of infection from the mother. Now, if the coming to the infant risk factors, in which the immature immune system is there of the baby. If this is a baby's preterm baby or low birth weight, less than 2.5 kg, if the first infant of multiple birth, altered skin integrity, immature GI tract, genetic susceptibility, HLA genotype, CCR5 karyotype deletion, all these factors can lead to high infection rates. And third, the infant feeding risk factors, in which mother infected with HIV while breastfeeding or mother breast pathologies, cracked nipples, mastitis or engorgement, advanced HIV diseases in the mother, poor maternal nutrition, mouth sores or ulcers or inflamed GI tract in the baby, mixed feed breastfeeding along with other foods or prolonged breastfeeding for 6 to 8 months are the commonest risk factors which can be there for the mother to child transmission. Breastfeeding is a big issue which has been controversial and people are asking for reviews. Should a baby be exposed? Should the baby be given breastfeed or not? Because so most of the time the obstetrician and pediatrician feel that the mother's milk is important as it has more of the vital foods that a baby needs. But exposing the baby to the virus in the mother can have a higher risk in which HIV when contracted can remain within the body for lifetime. So what is the agenda of PMTCT programs? The government program, they have prevention of mother-to-child transmission programs, offers a range of services for women of reproductive age living with or at risk of HIV. So it is not only living with HIV, or people with high risk of HIV, they can be also enrolled here. To maintain their health and stop the infants from acquiring HIV, there is a women part and there is a children part. So what do we do for the woman part? Woman part, that is before conception, we can have services for them. And throughout the pregnancy, labor and breastfeeding, there are all lot of support with them. For the children, what we do, we should include early infant diagnosis at 6 weeks after birth, testing at 18 months or when breastfeeding ends, and ART initiation as soon as possible for HIV exposed infants to prevent HIV acquisition. So we have to work on both panels, both parts, so that the woman, that is the mother, and the child, they get the best of solutions to prevent them from HIV. So, what are measures of the prevention of mother-to-child transmission that we should do? Number one, we have to do a pre-birth or pregnancy testing for HIV. So, according to CDC, the pregnant woman or women are planning to get pregnant, as well as partner, must take HIV test as soon as possible. So, it should not be just marriage. It should be that any person who thinks we are having a contact when then we are planning for pregnancy, you should always do a HIV test. Then PrEP to ensure safe conception. CDC describes PrEP HIV medicine for the partners. What is PrEP? Pre-exposure prophylaxis medicine for HIV negative women who are trying to conceive. This cuts down the risk of HIV transmission of HIV to the woman. So that can also be a possibility that should be done. Women who don't have rights, women don't have uh, areas in which they can give medical benefits or testing facilities like the sub-Saharan area. In these areas, we can also prescribe PrEP so that they can be controlled of HIV. Then safely planned delivery. Safely planned delivery is a boon. A C-section lessens the chance of HIV transmission to the baby. Pregnant women ensure timely ART prior to delivery, and the high viral load can become undetectable. Now, as we know, U equal to U, that is, undetectable viral load is untransmittable virus. So, if we can control the virus, we can control the infection. So, we should always try to a safe planned delivery. Then, food safety. There has been a case of HIV transmission among breastfeeding women with undetectable viral loads. WHO recommends formula milk in this patient subsets. So it's always better not to breastfeed so that the baby would be safe from HIV virus. So we also need counseling and family support. We need guidance and counseling from the right sources, and support of family members and friends are important. Most of the times, all doctors are not well versed with the HIV tactics, and therefore they are in a dilemma what to start and what not to start, how to work up, how to remain in the practice, because every parents feel that their child should be away from the disease, their child should make a better healthy life, their child should have a brighter future, and yes, that should be done, and that is only done only with the help of proper support of the family members, friends, and the doctors who can give the right way of treating and managing this dilemma. Also, take medicine to treat HIV. In case of HIV positive, encourage them to take HIV medicine as prescribed throughout the pregnancy and childbirth. Medication should be given to baby for 4 to 6 weeks after birth. So these are very important criteria. Though we have controlled everything, but the outcome of the workup of HIV virus in the body should not be neglected without taking ART for the child as well as the mother. So, what is the role of doctor in prevention of mother to child prevention of HIV? Number one, we have to provide the information to all pregnant women. Every pregnant woman, she should know what is HIV, why we are so much worried about HIV, and how we can prevent the transmission. Secondly, we have to educate the antenatal visits to their patients, so that they get the best of the knowledge and they get treated well. We have to have safe obstetric practices. We had a lot of issues reading the dies and people who do home delivery, so that when done in a proper way, we can have a better outcome of the disease. Also, minimize vaginal examination. Vaginal examination can lead to trauma, can lead to issues that can increase the burden of HIV. Also, avoid prolonged labor, premature rupture of membranes. These transmit the HIV to the baby since it is there in the birth canal. Avoid unnecessary trauma during delivery by minimizing the use of forceps or vacuum extractors. Best we can do is cesarean section, assessing the risk of post-operative complications beforehand, and follow standard immunization schedule so that the mother and the baby are safe. So just a brief history of PMTCT program. India initiated its PMTCT program in the year 2002. It aimed to prevent perinatal transmission of HIV from the infected mother to her baby, and the program entails counseling, testing of pregnant women in the integrated counseling and testing centers. So these are very important points, and therefore every woman who is pregnant or planning to be pregnant should get tested first. As on 2016, there are two 20,756 ICT centers in India, most in government hospitals, they provide PPTC services for pregnant women. Based on the WHO guidelines, the program initiates lifelong ART for all pregnant breastfeeding HIV women, regardless of CD4 counts. So we are very clear that we have to provide ART. This ART should be provided regardless of CD4 count, so that we get the best of the benefit. We get the lowest of the viral load, which is undetectable and which is untransmittable. During 2018-19, out of 13,760 babies exposed to HIV, 86% were initiated on ARV prophylaxis to prevent the transmission. So, the NACO or Government of India has made a lot of contribution identifying, segregating, and treating the women who are having dilemma or having some kind of infection of HIV to get treated. You see, there are PPTCT has 4 elements while treating this. We are to preventing HIV transmission among women and children. The number 1 is primary prevention of HIV, in which we see that the person HIV positive or negative, then prevent unintended pregnancies. So we know that sometimes there are pregnancies which are not intended. We should prevent them by using contraceptives. The prevention of mother-to-child transmission by giving proper ARVs and control things. And lastly, we all need care, we all need support, and we all need treatment. So HIV positive mother and child, linkages, referral, including all the facilities, will lead to a proper part of treatment management of HIV. What are challenges to implement the PPTCT? The first challenge is the significant proportion of the deliveries continue to be unsupervised. Home deliveries in many states. So these are the main things that happen. It's routine. People feel that they are safer, comfortable at the home, but not having a proper treatment agenda, not having a proper workup will spread the disease and will also have higher risk to the mother. Secondly, many of the hospital deliveries still remain uncovered by PPTCT for different reasons. Lot of times the people try to not disclose the information, and this will lead to higher number of infections. Most of the private institutional deliveries are not covered by PPTCT. This particular norm is a gap between the government and the private practitioners. Government should make up some kind of agenda in which they should contact and understand that some people need privacy. They want themselves to be treated in a better way or a way in which they have comfort. And therefore, these people should be given privilege of getting the medications. Now, so there are gaps initiating ART for the eligible HIV positive pregnant women mothers. So these gaps should be cut down, and we should work to see that any ART, any CD4 count, a pregnant woman should be treated with HIV drugs. And infant feeding practices, options for HIV exposed infants. There are varied perception, opinion, analysis, but the best is we can give them option foods. And a lot of times in the past 1,000 years of Indian history, we have seen that when the mother couldn't produce milk for her baby, we have already adopted cow milk, buffalo milk, or other milk, which can support the baby and keep ourselves away from the disease. So the WHO has sorted some guidelines on prevention. So we can have 4 points in which the providers and mothers they provide universal ARV therapy for HIV positive pregnant and breastfeeding women, regardless of the CD4 count. Provide daily prophylaxis for HIV exposed infants. Promote exclusive breastfeeding for 6 months, and engage and retain women in pre and postpartum HIV care to facilitate early diagnosis of the infants. So, the European guidelines and the THD guidelines, they have a lot of points which you should understand. In the international guidelines, if there is a pregnancy, one became pregnant while already on ART, you have to maintain the ART, but switch drugs that are potentially teratogenic. Woman became pregnant with treatment naive and whose fulfill the criteria CD4 for initial ART, then start ART at the second trimester is optimal. And lastly, women became pregnant while treatment naive, who do not fulfill the criteria of CD4 ART, start ART at the week 28 pregnancy and latest 12 weeks before delivery. Start earlier with high plasma risk of prematurity in the European part. But DHS says start ART may delay depending on CD4 cell count. HIV analysis fertility conditions say nausea vomiting must start on no later than 12 weeks. So it's important to start immediately so that we can give a proper treatment to the baby as well as mother. So the WHO recommends that if infants and young children are known to HIV positive, mothers are encouraged to exclusively breastfeed for the first 6 months and continue breastfeeding up to 2 years or beyond. But this is very difficult for, it's more of the WHO, UN, for the African countries or poor countries. But as the BIVA, British HIV guidelines says, mother living HIV, regardless of maternal viral load and ART, should refrain from breastfeeding from birth. So BIVA says refrain from breastfeeding because should not be provided access to infant formula milk. Should be provided access to infant formula milk and appropriate equipment including sterilizers and bottles under exceptional circumstances and after seeking expert professional advice. A highly informed and motivated mother might be assisted to breastfeed. So BIVA guidelines clearly say we should refrain from breastfeeding. So these are the things we should know and work up for the child to prevent the child from parent to child. There are a lot of other issues. Antenatal period, we should be giving nevirapine for them. So nevirapine can be started on the first day. It's 6 weeks we give, and we should also consider of treating them in detail. So ART for HIV pregnant women should be provided as a priority from the ART centers, and the principles of HIV management should be adopted there. The choice of HIV ART management of HIV infected pregnant woman is tenofovir, lamivudine efavirenz, that is TLE, that is commonly called, and these particular export infants, they should be this is the national guidelines. They should be given nevirapine, and the nevirapine should be worked up for 6 weeks, 6 months, 12 months, as per the data. Linkage to the ART center. So this is the preferred regime is at TDF plus TTC plus efavirenz, and if this doesn't work, then we can go to zadovudine, lamivudine, and efavirenz, or zadovudine, lamivudine, nevirapine, or zadovudine, lamivudine, and nevirapine. Sorry, tenofovir and nevirapine can also be used as alternative method. These are the care that we take during the postnatal period. So exclusive breastfeeds, 6 months, mothers have to take ART lifelong and give the nevirapine prophylaxis to them, and receiving replacement foods, mother, and they have to for 6 months. So same goes there, then, but we always try to avoid mixed feeding for both areas. These are the postpartum prophylaxis. If the patient comes, there is unknown baseline CD4, when direct labor, HIV positive during the work test, then we provide during the labor and delivery tenofovir, lamivudine, efavirenz, and after that process continue the same till we get the baby registered, and also baby we give them the proper nevirapine dose. In a special condition, when the patient of HIV 1 and 2 has come, then we consider it as HIV 2 and treat it as HIV 2. For that, we have tenofovir, lamivudine, and lopinavir, ritonavir boosted. For baby, we have zadovudine with the drug of choice. Syrup zadovudine is available 3 to 4 milligram per kg is the dose. So, when we conclude here, over the past decade, India has made a significant progress in tackling its HIV epidemic, especially compared to the other developing countries. We have done it the best. We adapted, we worked, recognized, developed, and treated the HIV positive person in a better way. The major reason for success is the sustained commitment of the Indian government through its National AIDS Control Program, which has been particularly effective at targeting high risk groups. All HIV mothers should be encouraged to take ART regimen as prescribed without interruption to pregnancy and childbirth. And more than 60% of pregnant women living with HIV received prevention of parent-to-child transmission in India in 2007. So it is efficient. Workup, HIV children are there. We can improve longevity and quality of life children, and we can treat patient with HIV and give a supportive. That's for it today. That's how I conclude on this prevention of child transmission.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one. I definitely think this session knowledge is going to help all the participants who have joined this session, sir. And sir, I can see, sir, we have received some question. If you allow, can I take this question?
Yeah, please. No need.
Yeah, I can see the first question is, what is the first and most critical step in reducing mother-to-child transmission?
The first step, we have to identify the mother is positive or not. When we identify at what stage of the ANC antenatal care the mother comes, and then when we should initiate the antiretroviral therapy for her. After that, when there is full term delivery, we need to go for the cesarean section. We need to consult the parents. We need to work up on the plan, and after that, after the delivery, we need to provide the ART for the pediatric or the newborn child. That's all the things which are important in this particular phase of preventing parent-to-child transmission.
Thank you so much, sir, for explaining that question, sir. Moving forward, I can see another question. The question is, what are the interventions for women diagnostic with HIV infection in labor and postpartum?
So, when the woman is diagnosed late in the labor, we have to see that if we can do a cesarean section, that will reduce the risk of the baby. Secondly, after the baby is delivered, then we have to ask not to refrain from breastfeeding and give appropriate nevirapine syrup to the baby. We have to check that the mother gets the best postpartum treatment. She avoids all kind of bleedings, and the baby also gets the best kind of treatment, which helps it to grow in a better way. The main cause of transmission of HIV more than 60% is during the normal labor when the baby is delivered, or if the procedures are done to like using forceps or giving episiotomy, which spills the blood and has the risk of transmitting the infection to the baby.
Thank you so much, sir, for answering this question, sir. I can see few more questions are there.
Yeah.
We will be taking last some questions, sir. And the question is, how long does a child take nevirapine after birth?
Okay, so the child has to take 4 to 6 weeks nevirapine every day, 4 to 6 weeks. That's how much we take. And if after 6 weeks we can do a test, and in that test, early test is that we can find out the baby is having infection now. But the confirmatory test is done at the 18 months of birth of the baby. So nevirapine should be given for 6 weeks ideally.
Okay, thank you so much, sir. I hope that participant have received his answer. I can see, sir, the couple of questions are there. We will be taking last two questions for today's session. And the question are, what are the guidelines for the prevention of mother-to-child HIV transmission?
What are the guidelines? So,
Yes,
as
sir.
we discussed, the guidelines are that a baby, the mother, when she should be first diagnosed of HIV, then when she is diagnosed, the stage of the HIV, then thirdly, we have seen the ANC part, first trimester, second trimester, third trimester. We should start the ART for the mother. We should work up and find any anomaly scan should be done for the baby, and if then the pregnancy is continued, we have to convince them for go for a cesarean section, and after cesarean section, we have to give nevirapine for the baby for 6 weeks. That's are the guidelines for the HIV PPTCT program in the normal way.
Thank you so much once again for sir explaining it and answering it really well, sir. I will be taking last question for today's session. And the question is, what are your views on concealing and follow-up of mother-baby pairs after discharge?
Yeah, the baby and the mother, they should be followed up uh, in a such a and they should consult that we should refrain from breastfeeding. Breastfeeding has a multiple exposure way. So if a baby is fed for 6 months twice a day, then we are exposing the baby to about more than 500 times. So there is a chance, a risk of transmit the infection to the baby. Secondly, we can have alternative fields. Alternative fields help us to decrease the HIV transmission from the mother to child. Third, the baby and mother should get all the vaccinations that are noted. So every vaccination important, and the baby should get all kind of vaccination. The mother should also be look for any kind of postpartum hemorrhages or any postpartum complications which may or might happen. And fourthly, the baby and mother should have a bonding and happy relationship. The baby should be given ARV in the liquid form. The mother should be given ARV in the tablet form, and they should be properly checked up and followed. Then after this, the testing of baby, and baby when tested, is he or she having HIV or not, we worked up. We have found out the ratio of transmission of HIV becomes so low, less than 0.001%. If the mother is delivered, mother does cesarean section, baby delivered by cesarean section, and not breastfed, and given ART, the transmission of HIV from this generation to the next generation will definitely be stopped, curtailed, and we will have a HIV-free generation in the coming years.
Thank you so much, sir, for answering all the questions, sir. It was a really wonderful session from your end, and I want to thanks once again for sparing your precious time here, sir. I hope that all the doubts of the participant has been clear. As I can see, there is no more questions, sir. Shall we conclude this session with all your permission?
Yeah, for us. Thank you very much.
Okay. Welcome, sir, and take care of yourself, sir. Hope to see you again with different topics, sir. It was a wonderful session, sir. Thank you once again.